Hi, I'm Liz Pekas. I will be presenting my project titled Dietary Nitrate Improves Vascular Function and Walking Capacity in Patients with Peripheral Artery Disease. It is well accepted that exposure to reduced gravity can have negative effects on the cardiovascular system both acutely and chronically. One of the first things that happens as one enters spaceflight is fluid redistribution that results in puffy face and bird leg syndrome. The face becomes puffy while the legs become thinner. This is due to the reduction in hydrostatic pressure. We are used to our blood being pulled down to our legs due to gravity, and in space the blood is no longer being pulled towards our feet. In this case, the head is experiencing a much higher blood pressure. This results in arterial baroreflex compensation. The baroreceptors are pressure sensors that detect stretch in the carotid arteries and aortic arch. They have a set point, so if blood pressure increases or decreases, adjustments are made to maintain a normal blood pressure. These adjustments result in reduced stroke volume and reduced heart rate in the attempt to reduce blood pressure to its normal set point. In prolonged exposure, the body adapts to these changes. The fluid distribution normalizes, and the blood pressure has dropped back to normal. However, upon returning to Earth, the body is considered to have experienced cardiovascular deconditioning. The baroreceptors adjusted to a different set point in space, often resulting in poor blood pressure regulation and brain perfusion upon returning from spaceflight. The heart and skeletal muscle also demonstrate reduced mass due to disuse, which can often result in reduced function. Additionally, the health of the vasculature also decreases when exposed to reduced gravity. Atherosclerosis refers to plaque manifestation and calcification of the arteries, which reduces blood flow and oxygen transport to muscles and other tissues. This can occur in the carotid arteries, coronary arteries, and also quite commonly in the legs, which is otherwise known as peripheral artery disease. PAD is an atherosclerotic disease that produces progressive narrowing and occlusion of the arteries in the legs. PAD most commonly presents as leg pain during walking, called claudication, which significantly reduces quality of life. In the more severe form, PAD can result in gangrene, ulcers, and tissue death, which may ultimately require amputation. Nearly 200 million people are affected by this disease worldwide, with healthcare costs totaling to nearly $4.37 billion annually in the U.S. alone. However, despite the increasing burden of this disease, pharmacotherapy and treatment options are fairly limited. Therefore, determining therapeutic targets are in urgent need. The endothelium lines the lumen of blood vessels and plays a key role in macronutrient and gas exchange between the blood and body tissues. It is also important for maintaining vascular homeostasis, such as vascular tone regulation. It is well accepted that endothelial dysfunction is an early event in the development of atherosclerosis, and endothelial dysfunction is often detectable before any structural changes within the vasculature become evident. Importantly, endothelial dysfunction, determined by brachial artery flow-mediated dilation, has been reported in patients with PAD and is lower than that of their age-matched healthy counterparts. There are several factors that are thought to contribute to endothelial dysfunction. It is often proposed to start with risk factors such as aging, hypertension, and obesity. These kinds of risk factors are thought to cause an increase in reactive oxygen species production, specifically superoxide anions. This ROS production exceeds the body's endogenous antioxidant capacity, which results in superoxide scavenging of nitric oxide, a potent vasodilator, which causes dysfunction of endothelial nitric oxide synthase and even greater ROS production. This results in a vicious cycle of ROS production, reduced NO bioavailability, and therefore endothelial damage and atherosclerosis. Therefore, improving endothelial function and NO bioavailability may be therapeutic targets to improve vascular function and reduce vascular damages in PAD. Normally functioning endothelial cells are stimulated to produce nitric oxide by mechanical stimuli, such as shear stress and release of acetylcholine. Acetylcholine then binds to the M3 receptors on the endothelial cells, which causes an increase in intracellular calcium in the endothelial cells and thus activation of eNOS to produce nitric oxide. This NO then diffuses into the smooth muscle cell and binds to the receptor guanylyl cyclase. This causes conversion of guanosine triphosphate to cyclic guanosine monophosphate, causing a reduction in intracellular calcium in the smooth muscle and dephosphorylation of myosin light chain kinase, which induces smooth muscle relaxation. In patients with PAD, this process is attenuated due to eNOS uncoupling and increased ROS production. Therefore, using a pathway that uses an exogenous source of NO may increase the capacity for vasodilation to improve blood flow and oxygen utility and transport to the skeletal muscle in patients with PAD. By exogenously inducing increases in nitric oxide by a nitric oxide donor, such as dietary nitrate, an endothelium-independent process of smooth muscle relaxation occurs by the NO3-NO2-NO pathway. This bypasses the endothelium to directly induce smooth muscle relaxation. Another potential benefit is the indirect scavenging of ROS, which may serve to improve endothelium-dependent vasodilatory function. In PAD, skeletal muscle mitochondria are a key source of ROS that causes cellular and mitochondrial damage. Superoxide anions rapidly scavenge endogenously produced nitric oxide, resulting in formation of peroxynitrate and reduced NO bioavailability, which causes vasodilatory capacity to decrease. Therefore, by adding an exogenous source of NO, the NO3, NO2, NO pathway may be beneficial to improve vasodilatory capacity in PAD who already have limited NO bioavailability due to ROS production. In order for the NO3, NO2, NO pathway to work, there must be a steady source of dietary nitrates. Although many vegetables contain nitrate, beetroot juice has been a very popular form of nitrate that is well researched in healthy populations, with little work done in diseased populations such as PAD. Beetroot juice is an easily accessible, inexpensive, natural supplement. Beetroot juice has also been shown to have beneficial effects in PAD, such as reductions in blood pressure, improvements in NO bioavailability, and improvements in exercise tolerance. However, there is a lack of knowledge about a dose normalized to body mass that may be beneficial for this population. Wiley and colleagues demonstrated a beneficial response in healthy adults following several quantified doses of dietary nitrate intake. For the present study, we chose a moderate level dose. A low dose may not be enough to elicit a detectable vascular response, whereas a high dose may induce side effects, such as nausea and headache. Therefore, the purpose of this study was to determine if acute beetroot juice intake can improve blood pressure, endothelial function, arterial stiffness, and exercise tolerance in patients with PAD. It was hypothesized that beetroot juice intake would improve NO bioavailability, which would improve endothelial function and reduce blood pressure in PAD. This improved endothelial function and reduced blood pressure would help reduce arterial stiffness, increase walking capacity, and delay time to claudication in this population. 11 subjects were recruited for participation in a randomized crossover study design. Descriptive measurements were assessed at the beginning of both visits, which were then followed by experimental measures, which I will address in greater detail. After experimental measures, participants were randomly assigned to receive either the nitrate beetroot juice supplement or the placebo for the first visit, and then received the opposite in their second visit after a 2-week washout period. Experimental measures included resting blood pressure and heart rate measured with an automated sphygmomanometer, brachial and popliteal endothelial function measured using flow-mediated dilation, central and peripheral arterial stiffness, which were assessed by pulse wave velocity analysis by applanation tonometry, and exercise tolerance, which was assessed by using a maximal walking capacity test on a standard treadmill. Data were analyzed with a 2x2 repeated measures ANOVA. A p-value of less than 0.05 was considered significant, and paired t-tests were used for post-hoc comparisons. The supplement was well tolerated by all participants, and participant characteristics were not different between the two study visits. Endothelial function in the brachial artery significantly improved after nitrate intake, and this was significantly greater than placebo. Popliteal artery endothelial function also significantly improved following nitrate intake. Systolic and central systolic blood pressure were also significantly reduced. In particular, the reductions in blood pressure may be considered clinically relevant. Epidemiological data have reported that a reduction in resting systolic blood pressure by as little as 2 millimeters of mercury is likely to reduce chance of mortality due to stroke and coronary heart disease by as much as 6%. Therefore, a reduction of about 5 millimeters of mercury following acute nitrate intake may have potential clinical implications for patients with PAD. There were no significant changes in central or peripheral arterial stiffness following acute nitrate intake. There were significant improvements in maximal walking distance and maximal walking time following nitrate intake. However, there were no significant changes in the time to onset of claudication. These results may be due, in part, to the improvements in endothelial function and reduced blood pressure following nitrate intake, therefore allowing improved blood flow and oxygen transport and utilization to the lower extremity. Our previous studies involving 12 weeks of heated water exercise training and land-based exercise training for PAD patients demonstrated improvements in time to onset of claudication by 41% and 30% respectively. The present study demonstrates an improvement in time to onset of claudication by 10%, which may suggest that an acute dose of nitrate may provide nearly 1/3 of the benefits received from 12 weeks of supervised exercise therapy for patients with PAD. Additionally, walking distance improved by about 90 meters following nitrate intake. It has been demonstrated that an improvement in walking distance by 40 meters is considered a large, meaningful clinical improvement in patients with PAD. Therefore, an acute dose of nitrate may result in a large, clinically meaningful improvement in walking distance in patients with PAD. A moderate dose of dietary nitrate in the form of beetroot juice is beneficial for improving endothelial function and reducing blood pressure in PAD. These improvements in endothelial function and reduced blood pressure may have played a role for improving exercise tolerance in this population. Future direction for this study includes analysis of nitric oxide bioavailability in the plasma and analysis of oxygen utility capacity assessment by near-infrared spectroscopy. As for future studies, supplementation studies and the application of nitrate intake and vascular function for spaceflight are warranted. This project was funded by the University of Nebraska at Omaha and the NASA Nebraska Space Grant.